Good morning, everyone. Santosh deemed to be University welcomes all of you for National Health Skill Conclave 2020. I'm Dr. Kanika Bhalla from Department of Oral Pathology. Today, I'll be giving a presentation of exfoliative cytology. This presentation will be followed by a video and then its interpretation and the pap staining. Good morning, everyone. Welcome to National Health Skill Conclave 2020. I'm Dr. Kanika Bhalla from the Department of Oral Pathology. I welcome you all on behalf of Santosh Team to be University. Today we are talking about a cytopathological technique, exfoliative cytology. It is a chair-side procedure. So first let me just tell you a very basic principle of exfoliative cytology. Exfoliation basically means shedding, aberration of the superficial surface of the oral mucosa. Exfoliation mainly what happens when the epithelial cells from the deeper layer to the superficial layer, there's a turnover time and the cells grow and eventually they shed. It is a normal physiological process. But in case of any pathology, along with the superficial cells, the deeper cells of the deeper layer also become non-cohesive. There is loss of cohesiveness and they also start to shed off, and when we scrape these cells off with the help of our instruments and take them, so they can be studied with the help of our special cytopathological techniques. This is the basic principle. Now what are the advantages of this technique is, it is a chair-side procedure, it is very simple procedure, it is painless, it is non-invasive and a bloodless procedure. But it is only an adjunct to biopsy, but not the replacement. It is a screening procedure, not a confirmatory procedure. And there are various lesions in which we can do it. We'll talk about it a little later. Now first we'll talk about the armamentarium, and I will show you here. These are the instruments that we need for the procedure. We scrape off the epithelial cells with the help of either a wooden blade or a metallic spatula, and we have special cyto brushes also. Then after scraping it off and removing the debris with the help of a wet gauze piece, we spread every surface of the cell evenly on the microscopic slide, and then we use a biofix spray. These are the fixatives which are used to fix the epithelial cells, otherwise they go dry and the morphology can be distorted. And after fixing, we go for staining procedure. So I will demonstrate you the exfoliative cytology technique in a simple way. The first thing that we need to do is, we need to, please remove your mask. We need to, wherever the lesion is present, we need to just wipe off the extra debris and the mucin present on the lesion. After doing this, we take the metallic spatula, or you can take the wooden spatula also, and we vigorously scrape off the lesion so that the epithelial cells come on the blade. As you can see, we are just vigorously taking the epithelial cells, and immediately taking them, we just spread them evenly on the surface of the microscopic slide. After they have been spread evenly, we need to just fix them immediately with the help of this biofix spray. We need to make sure that the fixing is done immediately. So after we have fixed the slide and we have made sure that the fixing has been done immediately so that the architecture of the epithelial cell is maintained, we keep aside and we take another slide. So the principle of taking a duplicate slide is that if we need to use another stain to see some other special kind of cell, so we have to have two samples together from the same lesion. And secondly, we also need to make sure that the air drying of the slide takes 30 minutes, and after air drying for 30 minutes, we go for the staining. We normally use rapid pap kit. This is our staining station. We use the rapid pap kit and we do the staining. H&E stain can also be used, and there are various different kind of cells which are seen in the lesion. Here, after the lesion has been stained and we see it under the microscope, it has been divided into 5 main categories. The normal first category 1 is where the cells have their normal morphology, that there is no architectural loss and the cells have so this we consider as a normal, there is no abnormality or no pathology. Class 2 smear is the abnormal smear where there is minor atypia. Atypia means some atypical cells where there are changes in the nucleus and the cytoplasmic architecture of the cell. Here the biopsy is not recommended. Third is the intermediate class 3,
where there is minor atypia seen, but it is not a clear-cut case. So we basically recommend the biopsy for these lesions. Class 4 is the clear-cut case where we see the atypical cells a lot, and it is definitely going for biopsy, and there are major atypical changes. And class 5 is a malignant lesion where definitive atypia is seen all over in every cell, and it is definitive for malignant lesion. Here is a photograph where I want to show you. These are the cells which are not showing any atypia. These are the normal cells where the nucleus and the cytoplasm, these has been stained with pap stain, and they show the normal architecture of the epithelial cells. As you can see here, the nucleus is small and the cytoplasm, they are maintaining their normal ratio, which is 1:4. As against this second image, ABC, these are showing atypical cells. What we mean by atypical cells is that the normal architecture of the nucleus and the cytoplasm is not being maintained properly. The nucleus is oversized, it is bigger, and the ratio has almost become 1:1. And there is hyperchromatic nucleus, that means the nucleus is taken darker stain than usual. So these various atypical changes when they are seen, so in the microscope we see these cytological changes, whether the slide is normal or it is pathological. Now the indications for this procedure, normally if you have a lesion which is intact, the surface is very sound, for example for a fibroma, we normally do not go for cytology and we directly just excise the lesion. Even for lesions like leukoplakia, we do not go for cytology because we will not get anything but superficial keratin only. So the lesions which have specific cells, for example, pemphigus, herpes simplex and herpes zoster, where we can see TZANCK cells, these are the major indications and the lesions in which we go for exfoliative cytology. Another lesion like sickle cell anemia and white sponge nevus. So exfoliative cytology is basically not a definitive screening, it is a screening procedure and only meant for specific lesions. It helps to also to tell us about the recurrence also. So before going for an invasive procedure, which is biopsy, where the patient has to lose, it is invasive, has to go some pain, and even it is not even bloodless, we prefer to go for this screening procedure so that it gives us the hint of whether it is malignant or not. We go for biopsy later.
So now we move on to the next level of our presentation. Now we will, after we have fixed the slide, we will go for the papanicular or pap stain. Now this stain, basically it is a universal stain which is used for the cytological smears in cancer diagnosis, and it basically aims to detect the potential of the potential precancerous changes. So advantages of this pap stain is that it gives a very good definition of the nuclear details, and for the cytoplasmic details, even if there is multi-layering, then the aggregates can be seen because of the transparency. The regions that we mainly use in a rapid pap kit is Harry's hematoxylin, orange G6 which stains the keratin, and hematoxylin stains the nucleus, and EA is eosin azure 50 which stains the superficial epithelial squamous cells, and light green SF also stains the cytoplasm. Now, I've made a flowchart to just quickly go through the technique of the pap stain. After fixing the slide, we circulate it in alcohol 70% and 50%, and then it is washed in distilled water. And then it is dipped in Harry's hematoxylin so that the nucleus takes the blue stain. Then it is washed in tap water. Then it is again dehydrated from alcohol 50 to 70 to 90% and 10 dips each. Then it is put and dipped in orange G6 for 1.5 minutes. Then again it is washed in alcohol. Again dipped in eosinazole for 2 minutes. Again washed in 3 steps of alcohol, 10 dips each. Then again washed in absolute alcohol. Then it is cleared in xylene, which is the clearing agent. And then the slide is dried and it is mounted. And then the slide is ready for the microscopic examination. This is the fixative that we use, the biofix spray. We can also use a 50% mixture, equal quantity of alcohol and ether, or otherwise this ready-made commercial sprays are also available. This is a rapid pap kit that we use. These are the reagents, the eosin azure, orange G6 and Harry's hematoxylin. Now, the combination of this orange G6 and eosin azure gives a very subtle range of green, blue, and pink hues. And this is actually the beauty of this stain, because then it tells the transparency quality, and everything, that the cell, the superficial cells, the nucleus, they're stained differently. Like as we see in this slide, the nucleus of every cell has been stained blue, which is because of the Harry's hematoxylin, and the cytoplasm has taken the blue or the green color. These are for the epithelial cells, but whereas the keratinizing cells and the superficial cells have taken up a hue of orange color. So this varying degree of blue to pink and orange gives a range of PAP stain. Now, once we are done with the stain, how do we interpret? In the video also, we spoke about the 5 categories of the stain. Before going to that category, we will just speak about a little that what is normal and what is abnormal. In this slide, you see that there are certain normal cell cytology as well as the nuclear cytology. This image shows normal cytology of the cells and the nucleus. Every nucleus, if you can see, has a proper small ratio as compared to the cytoplasm. And the shape of every cell is polygonal, which is actually descriptive of every epithelial cell. But when it comes in contrast with those cells which are atypical, if you see here the small comparison, the normal cells have good shape, the polygonal shape they've maintained, and the nucleus, and the ratio of the nucleus to cytoplasm also. Whereas, I'm sorry for the little haziness of the image. And this is the nucleus which has a larger stain. It is darkly stained hyperchromatic nucleus with the irregular shape of both nucleus as well as the cytoplasm. The cellular as well as nuclear abnormalities can vary. They might be increase in the shape and in the size of the nucleus. Then pleomorphism, as in the shape is altered of the nucleus as well as the cytoplasm. There is multinucleation, abnormal mitosis, and aberrant chromatic patterns. And in cytoplasm, the cytoplasm can be scanty, obviously because the nucleus has overgrown and the ratio has been disturbed. And there can be vacuolization and inclusions and altered staining patterns also. Now, the 5 categories that we have spoken about is, the first was the class 1, the normal category. Here, we do not see the typical cells. There are no atypical cells. That means this is a normal cytological smear where the epithelial cells are polygonal, the nuclear to cytoplasmic ratio is normal, and the staining is also normal. When we come to class 2, there we can say only slightly atypical cells. As you can see here, these are inflammatory cells, and only slight increase in the nuclear changes have been seen, but it is not definitive of any kind of suspicion. So we normally do not recommend biopsy in class 2. These changes are mainly because of the inflammatory changes. Class 3 shows atypical cells. If you see in this slide, there are changes in the nucleus size also, and a little staining has also been changed. So here the biopsy is recommended. For class 4 smear, there are many atypical cells. If you see here, the pattern of the shape and the size of the nucleus has been altered. The ratio has been altered. They're bigger in size. The shapes have been altered. So this lesion is probably malignant, and biopsy is mandatory. And the last is the class 5 lesion, where it is sure that the lesion is malignant. And you can also see the aggressiveness of the lesion, because the nucleus has so many inclusion. It is shrunken, and it has inclusions in it, and there is a prominent nucleoli, and the size of the nucleus is bigger, and the shapes of the cytoplasm and the entire cellular outline has been lost. So the biopsy has to be done, and this is a sure shot case of a malignant lesion. Now, other than these 5 typical lesions, I would like to show you some classical cases where we see the specific type of cells. For example, we see lesions like pemphigus and herpes, where we see the ZANK cells. Now, ZANK cells are basically typical those cells which have lost their cohesiveness because of the desmosomal junctions have been autoimmune because of autoimmunity. So they tend to become circular because to attain the smaller surface area. So if you notice here in these slides, which has been marked by red arrow, these circular cells, these are the ZANK cells. You can appreciate that there is total loss of the shape of the typical polygonal epithelial cells, and these have become round cells, and they are all ZANK cells. So in such lesions like pemphigus and herpes, ZANK cell smear are very much of importance. Also, in certain fungal and bacterial infections, this is a particular lesion where we can see candidal hyphae. These elongated hyphae are the candidal hyphae, and this is descriptive of fungal infection, and this is bacterial infection, actinomycosis. So these lesions where we suspect a typical kind of cell, the indication for exfoliative cytology is very much recommended. Thank you so much. I hope you understood a little bit of this presentation. And if you have any query, we are open for discussion. Thank you.